today. Just a note that we will be recording today's webinar. I'd like to introduce our speakers for today. So we have Dr. Preeti Pathela, who is the Executive Director of the STI program in the Bureau of Hepatitis, HIV, and STI at the New York City Department of Health and Mental Hygiene. She has overall responsibility for directing, evaluating, and coordinating the activities of the program. She has 19 years of experience in the field of STI HIV prevention and control and serves on the American STD Association's Board of Directors and as an associate editor of the Journal of Sexually Transmitted Diseases. Before we get started with today's talks, I did want to launch a poll just to get a better sense around DoxyPEP and what's happening here in New York City. So there should be a poll that pops up on your screen regarding whether your facility organization is currently providing DoxyPEP. Okay, great. We'll just give it another few seconds and then close the poll. This is just really helpful for us to get a better sense of what's happening here in New York City. Okay, so this just is a little screenshot of what the poll results are. Looks like about half of you are doing it on site. Some of you know plans currently, and some of you are referring out. So thanks so much for answering that poll for us. And now I'd like to turn it over to Dr. Pathela for the first part of today's presentation.
Thanks so much, Gary. Hello, everyone. Good afternoon. Thank you for being here. I'm really delighted to be co-presenting with Dr. Zucker on DoxyPEP, and the title of my presentation, or my part of the presentation, is The Science, Current Guidance, and Considerations for Implementation. And I'll be going over a few things in this talk. One, to just kind of set the stage, I'll be presenting some trends in the incidence of bacterial STIs here in the city, providing data from recent studies establishing the efficacy of DoxyPEP in preventing bacterial STIs, providing examples of local and national guidance for DoxyPEP use. That's not kind of all-encompassing or comprehensive, but just a smattering of various guidance that we have seen come out, and then touching upon some implementation considerations as the uptake of DoxyPEP increases. So I just wanted to kind of as like a primer or maybe a reminder for folks, let you know how we hear about STIs here at the health department. We receive reports from providers and laboratories for several infectious diseases, including sexually transmitted infections, and that's required by law in the New York City Health Code. We get basic demographic information on people who are being tested, and that's required to be reported to us within 24 hours of diagnosis for all but one of the infections that you see on this slide. Mpox is immediately reportable when suspected, but we generally get name, address, and date of birth for people who are tested for STIs. Test positive rather, and we get a large number reported to us every year. So in 2022, we had over 63,000 chlamydia reports, over 29,000 gonorrhea reports. For syphilis, adult syphilis, about 8,000 cases. Oh, sorry, more than that. It was more like 11,000 cases. We also had 19 congenital syphilis cases reported to us in 2022. And Mpox cases, this was the year of the big outbreak that we had here in this country and in other parts of the world. And so we counted about 3,800 Mpox cases that year. And so, just as kind of like a reminder or maybe new information for some folks, I had mentioned that we have, these reporting requirements. We get provider reports and laboratory reports, and those numbers that I presented to you in terms of cases, we really generally know about from lab reporting and not from an accompanying provider report. But those provider reports are really important. They're very valuable because they contain information that is not available in those laboratory reports, such as some more granular information on patient demographics, symptoms that were, reported, at the time of care seeking, what treatments were provided, the patient's gender of their partners, and then some partner management strategies. We'll get information on that provider report form, which is known to some as your universal report form, and it can be submitted online, or it can be called in, it can be faxed in, a variety of ways that we accept those reports. In addition, so we get this expedited partner therapy information. We also get information on the patient's PrEP use, whether it was offered and whether they're using it. And then, as I mentioned, information about gender of partners. And soon, related to this presentation, we will be adding a field or a little section on DoxyPEP use as well. Unfortunately, for all of the reports that we know about with STIs, only about a third of them have a provider report. So we are missing a lot of this really granular information that helps us better characterize the epidemiology of STIs in New York City. So these are the trends that we have seen over a great number of years, from 2007 through 2022. And a few things I just want to point out here is that we're looking at two different y-axes for this graph. The one on the left, the red one, corresponds to case rates for chlamydia and gonorrhea, and the one on the right in purple has case rates that correspond to HIV, new HIV diagnoses, and primary and secondary syphilis. And so the scales for those two y-axes, as you can see, are very different, going up to 1,000 per 100,000 when it comes to chlamydia and gonorrhea. And the other big thing to point out here is that we've had real success when it comes to HIV diagnoses and HIV prevention in the city, thanks to things like events like the emergence and availability of HIV pre-exposure prophylaxis, HIV post-exposure prophylaxis, increased testing, better linkage to care, good viral suppression rates that are related to, the concept of undetectable equals untransmittable. So all very good things that have helped to bring down HIV diagnoses rates in the city. But at the same time, you can see trends for the other bacterial STIs presented here really increasing over time. And we do see dips, of course, in 2020 that are related to the COVID-19 pandemic and the fact that there was less healthcare seeking and detection of those infections during that year. So again, STIs rising while HIV diagnoses decline in the city. And what you see here is really driven by increases among people reported to us as men. And so the overall picture that I just showed you is pretty much the same, just for those who are reported to us as male. And with females, we see a little bit of a different pattern here where things are quite steady, and even for some, a little bit of a decline. However, again, very high rates when we're talking about some of these infections like chlamydia and gonorrhea. So moving on to the topic of this presentation and doxycycline post-exposure prophylaxis, or DoxyPEP. Given the fact that we have these really high rates that have been increasing, we needed an intervention. And doxycycline is a great one, in that one of the upsides is that it's safe, it's well tolerated, it's inexpensive. An initial study in Los Angeles had examined the effect of doxycycline prophylaxis on STI prevention. And it was a small pilot of 30 men who have sex with men with HIV. It found a 73% reduction in incident cases of syphilis, gonorrhea, and chlamydia among those taking daily doxy as STI pre-exposure prophylaxis. So this was doxy PrEP, not PEP. But subsequently, and more recently, we have 3 randomized control trials that show great efficacy of doxy-PEP in the prevention of STIs, all among MSM, with one that also included transgender women. But unfortunately, the evidence is not there for cisgender women. And that is one of the concerns that you can see here on the right side of the slide. Others are that there are concerns that the kind of extended use of DoxyPEP could increase the prevalence of tetracycline-resistant gonorrhea. It is important to note that tetracyclines are not used as first-line treatment for gonorrhea. There are concerns about the impact of intermittent doxy use on drug resistance, and also some concerns about any impacts on a person's microbiome with with kind of extended DoxyPEP use. Dr. Zucker will go through into depth about what's known when it comes to potential threats of antimicrobial resistance. I'll just say that the potential risks of resistance must be weighed against the reduction of STI incidence with DoxyPEP, which will prevent transmission and result in less antibiotic exposure for treating kind of established infections downstream. And of course, we need things like appropriate genomic surveillance to further understand threats of antimicrobial resistance. I imagine that there will be leveraging of existing national surveillance programs. There are a couple of them that have been longstanding. One is called the Gonococcal Isolate Surveillance Project, or just for short. The other is strengthening the U.S. response to resistant gonorrhea, known as SURGE. These are both CDC projects, surveillance mechanisms, and I think as DoxyPEP is increasingly implemented, those systems will be significantly scaled up to adequately assess the potential impact of antimicrobial resistance and DoxyPEP. So now turning to the studies, the 3 studies that I just mentioned. These are the studies that are among men who have sex with men and transgender women. This is a graphic that is taken from a Dear Colleague letter on DoxyPEP that we released, the health department put out last fall. And I'm just highlighting here, kind of stacking up these studies one against another so you can see the relative reduction in STIs associated with all of them. But I will now go into kind of some detail on each of them individually. So the first one is IPERGAY. This was an open label extension of a French National HIV Research Agency's study that found significantly lower chlamydia and syphilis incident infections among men who have sex with men without HIV who were taking event-driven HIV pre-exposure prophylaxis. And they were randomized to doxycycline 200 milligrams taken within 72 hours of condomless sex, and found a relative reduction of 70 to 73% in the intention to treat analysis. You can see here that the relative risk reduction in STIs overall is only 47%, because DoxyPEP actually did not decrease gonorrhea, likely because of the high prevalence of doxycycline-resistant gonorrhea in the population that was being studied, so in France. And background resistance rates widely vary in the locations of these studies. For gonorrhea, tetracycline resistance is estimated to be 20% in the US versus what it was in France, 56% during the time of IPERGAY. And then this is the study that took place in or recruited participants from Seattle and San Francisco. That was big news a couple of years ago, the DoxyPEP study. It was powered to separately assess DoxyPEP effectiveness in men who have sex with men and transgender women who were either receiving HIV PrEP or were people living with HIV. And in this open label randomized controlled trial, participants were randomized 2-to-1 to the DoxyPEP arm, in which they took doxycycline 200 milligrams within 24 to 72 hours after condomless sex versus a standard of care without DoxyPEP. Participants were followed for 12 months with quarterly STI screening, and there was no difference found in the self-reported number of sexual partners between the groups. In the PrEP cohort, at least one STI was diagnosed in 10.7% of quarterly visits, and that was in the DoxyPEP group, and then 31.9% of visits in the standard of care group, with a 0.34 relative risk of STI acquisition, and that equates to that 66% relative reduction that you see there. In the cohort of people with HIV, at least one STI was diagnosed in 11.8% of quarterly visits in the DoxyPEP group, and 30.5% in the standard of care group, with a relative risk of 0.38. Notably, DoxyPEP was associated that was a statistically significant decrease in each STI, with a 55% reduction overall per quarter for gonorrhea and approximately 80% reduction for early syphilis and chlamydia. And then the number needed to treat to prevent an incident STI during a quarterly follow-up visit was 4.7 in the PrEP cohort and 5.3 in the cohort of people living with HIV. And then this DoxyVax study, this was conducted in France. It was as a sub-study within the IPERGAY PrEP cohort, and it examined the use of DoxyPEP to prevent chlamydia and syphilis. Participants were randomized 2-to-1 to receive DoxyPEP, same regimen, 200 milligrams, 24 to 74 hours after a condomless sexual encounter. And then the other arm was no DoxyPEP. Interim analyses included 332 men randomized to DoxyPEP versus 170 to no DoxyPEP. And you can see the positive effect that we saw in this study as well. And then the last thing that I'll just say about the studies, there's so much in these studies, including what Jason's going to present on antimicrobial resistance that was observed or evaluated. But I'll just say that in addition to the overall reduction in STI that was seen in these studies, there was also a significant difference between the two arms in the DoxyPEP study and the DoxyVac study in time to first STI. And now moving on to the DPEP study. So this was a randomized trial of DoxyPEP 200 milligrams taken within 72 hours of sex compared to the standard of care. And this was among cis women in Kenya, consisted of quarterly screening and treatment for STIs. There were 449 participants, ages 18 to 30 years on HIV PrEP, and DoxyPEP was continued while women were pregnant. And you can see here that 18% had an STI at enrollment. The annual STI incidence during the study period was 27%, so relatively high. And there were no significant differences in incident STI events between the DoxyPEP group and the standard of care group, with 109 new STIs detected over that time period, 50 in the DoxyPEP arm, 59 in the standard of care arm. 78% of those new STI were chlamydial infections. And again, no real differences seen between the two arms when it came to chlamydia. So that was certainly disappointing news. And this is a slide that was presented at the CORE meeting back in 2023, just last year, from the lead author of this study, really putting out there, positing why DoxyPEP would not have been effective for STI prevention in cis women in this study, and then various reasons for that related to anatomy, to exposures, and to resistance were proposed. Really adherence was the one that stuck out the most. So among 50 randomly selected participants who were assigned to the DoxyPEP arm, doxycycline was detected in only 58 of 200 hair samples that were collected. That's just 29%. And that raised concerns about the lack of effectiveness being in part due to low adherence to the DoxyPEP regimen. There was another pilot study in Canada, again, among MSM. These were MSM who were on daily HIV PrEP. And this was called a dual daily HIV and syphilis PrEP cohort, or DUDIS for short. And it looked at Doxy as daily PrEP in those who had a syphilis infection in the prior 36 months. There were 52 participants randomized 1-to-1 to getting immediate Doxy PrEP, 100 milligrams daily versus delayed initiation after 24 weeks. And during the first 24 weeks, there were 4 STIs, all of which were gonorrhea in the immediate Doxy PrEP arm, and 19 STIs, which were a mix of syphilis, chlamydia, and gonorrhea in the delayed treatment arm. So doxycycline was associated with reduced probability of any STI with an odds ratio of 0.18 during that follow-up. So in summary, the current evidence demonstrates consistent efficacy of doxycycline prophylaxis for the prevention of STIs in MSM and in transgender women, with higher efficacy for syphilis and chlamydia than for gonorrhea, and more information is needed to understand the effectiveness in people who are assigned female at birth. So other considerations include safety and adverse events. In the DoxyPEP, DoxyVac, and DUDIS studies, no doxycycline-related serious adverse events were reported. There were 3 participants in the DPEP study that reported 4 instances of social harm, which included verbal or physical violence. A recent systematic review of 67 studies reporting adverse event data with doxycycline use found that longer-term use of doxycycline, defined as greater than 8 weeks, was found to be generally safe with minimal side effects. And then when it comes to acceptability and attitudes towards doxy prophylaxis, there have been multiple studies of both community members and clinicians that demonstrate high rates of acceptability of this intervention. The concerns that are raised are related to antimicrobial resistance and long-term safety data. And then, in many of these surveys that have now taken place quite some time ago, getting official guidelines that was really cited as things that were needed to facilitate adoption. And that brings me to talking about some guidelines. And so the U.S. Centers of Disease Control and Prevention, or CDC, has yet to release official guidelines on the use of DoxyPEP, but several health departments and other agencies have created protocols regarding DoxyPEP use with varying strength of guidance for priority populations. Australian and German interim position statements support DoxyPEP, particularly for syphilis prevention, which you can see here on the slide, that DoxyPEP should be considered primarily for the prevention of syphilis, is what was stated in this consensus statement. So these are from Australia, and you can see here that while syphilis was really a focus of this, in the second block of text here, you can see that there are different groups here who can be considered in these guidelines, according to these guidelines, for the offer of DoxyPEP. And then interestingly, in these particular guidelines, there is some information about the recommendation for using DoxyPEP for just a predefined period, rather short period, followed by review of the need for ongoing use, which we haven't seen in really in others. So on the other hand, the British Association of Sexual Health and HIV does not currently endorse DoxyPEP for anyone with concerns about resistance that they feel outweigh the benefits of use. And now moving to the US and some specific jurisdictional guidance. The first one here is from Seattle and Kings County, which I'd be interested to know if Jason felt the same way, but I really liked this guidance when it came out. One thing to say here about Seattle versus San Francisco versus New York State versus New York City, which I'll also be showing on the next slide, is that, there's just very different language that is used across all of these guidance documents. And so it kind of becomes confusing because Seattle, Kings County says, medical providers should inform their patients, and the patients that they really focus on are cisgender MSM and transgender women who have sex with men with a history of bacterial STI in the prior year. So really conforming to the groups that were in the major trials that I presented. When we look at San Francisco, they say instead of informed to recommend DoxyPEP to those same populations, but then they expand, or rather add another criterion saying they should have had a bacterial STI in the past year and also report condomless sex with at least one cis male or trans female partner in the past year. But then they also have this recommendation, which is to offer DoxyPEP using shared decision making to groups that kind of can fall out of that. So they can be cis men, and trans women who report having partners who are cis male or trans female partners or trans females, but they don't have to necessarily have been previously diagnosed with an STI. And then moving over to New York State guidance. So we've got the word offer here, the population of cisgender men and transgender women who engage in condomless sex with partners who are assigned male sex at birth and have had a bacterial STI within the last year, but then add on our ongoing risk of STI exposure. And that applies to both these populations who are taking HIV PrEP and also those who are not on HIV PrEP or in HIV care. And then there is this third bullet that says that clinicians should engage in shared decision making. And this is rather new, and we didn't see this in the other guidance that I provided, that it could be also provided for cisgender men who engage in condomless sex with multiple partners who are assigned female sex at birth. So here we could be talking about heterosexual men as well who have had a bacterial STI diagnosed within the past year. And then here is our guidance that came out last fall, and our recommendations use even different language than what you've seen. So we say that the provider should prescribe based on shared decision making to MSM and transgender women with a history of bacterial STIs recently in the prior year, and really focus on those with a history of syphilis or those who have had multiple STIs. And then since we put out this in a Dear Colleague letter, we've had some ancillary materials to kind of help with navigating, the instructions about how to take DoxyPEP that's available on our website. And then I'm almost to the end here. I'm just going to touch upon like what we might think is going to happen in terms of the impact of increased DoxyPEP use in target population. So there is a study from Fenway Health, which is a large LGBTQ focused health center in Boston. They used data on over 10,000 people assigned male at birth who had 2 or more STI tests between 2015 and 2020. And they examined 10 potential DoxyPEP prescribing strategies to minimize use while maximizing impact on STIs. And found that prescribing DoxyPEP to individuals, particularly with concurrent or repeated STIs, could avert a substantial proportion of all STI diagnoses. And I know that Jason will be kind of talking further about this study, so you'll hear more about that. Then there was another study in Philadelphia. This was using agent-based models to assess population level impact with one of the key inputs being surveillance data. And in this study, it was found that an uptake scenario of 20% with 80% adherence would reduce cumulative syphilis incidence by 10% over the next decade, while 22% of syphilis cases could be prevented in instances where condoms were not used. So it would be a missed opportunity not to talk about equity and trying to avoid kind of like historical pitfalls that we have seen with the rollout of other biomedical prevention interventions. In terms of racial and ethnic disparities, as a novel biomedical intervention, there are valid parallels to HIV PrEP to consider for DoxyPEP. Current disparities in HIV PrEP coverage among groups disproportionately affected by HIV really forecast what we can expect from DoxyPEP unless equitable implementation and delivery are prioritized. And successful implementation and uptake of DoxyPEP will depend on the identification of community-informed delivery strategies that meet the needs of diverse groups. Of equal importance, clinicians and other healthcare providers must improve capacity for delivering culturally competent, inclusive, affirming care that's centered on pleasure and sexual wellness for this to really work well. And then in terms of gender disparities, cisgender women, transgender men, and non-binary persons assigned female at birth find themselves in a really unfortunate familiar position where their needs for effective sexual health interventions remain unmet. Bacterial STIs have potentially severe, devastating consequences involving the female genital tract. Additionally, prevention of syphilis to avert congenital syphilis is critical. And so more DoxyPEP efficacy trials that include cisgender women and people assigned female at birth, regardless of gender, are warranted and unfortunately are not underway at this time. I just want to end with some next steps for the health department, so everyone's just kind of aware of the kind of great variety of work that we are engaged with and on regarding DoxyPEP. So as I mentioned early on in this presentation, we have a provider report form. We aim to start collecting a population level measure of use via that reporting form. We are providing education and soon we'll be collecting information on the use of DoxyPEP among patients and partners with whom we are in touch who are receiving case investigations and partner services for incident STIs. We will be soliciting feedback from community members on their experiences with DoxyPEP, positive, negative, all of the challenges. We have done surveys in sexual health clinics to kind of understand at baseline what people's awareness and acceptability of this intervention looks like, but ongoing qualitative assessments to really understand kind of pain points and barriers and also successes of the program in these clinics as they kind of the program rolls out there will be invaluable. And then understanding also from electronic medical records and data analysis what uptake and use patterns look like specifically in our sexual health clinics that can really inform gaps and where we might be seeing some health inequities. And I will just end now with a plug for our 2022 surveillance report, which I'm happy to say came out yesterday, and it was accompanied by a press release. It's on our website, and in that press release, Dr. Jason Zucker, to whom I'm going to turn over this presentation in just 1 minute, provided this really great quote. So I'm just leaving it up here on the screen for everybody to read. really highlighting the fact that this is an important public health strategy at a time when we have really alarming STI rates and really very seemingly insurmountable, though I know that we can do it, inequities in STIs as well. And with that, I will stop sharing my screen. And Jason, over to you.
Well, thank you so much. That was a fantastic, not surprising summary of what we know so far. I'm going to hopefully talk a little bit more about sort of clinical practice and ways that we can implement this. And, Preeti put up the quote that I gave to the Department of Health. And I think one of the key parts of that quote is the idea of tactical. And it's the idea that we want to maximize the benefits of this intervention while we minimize the risks. And that's what we're going to talk a lot about today. So I always like to start by just reminding people that, DoxyPEP is just one piece of our STI prevention landscape. We need to be thinking about both primary and secondary prevention. Primary prevention really focuses on avoiding disease entirely. These are interventions done before a disease occurs. Things like condoms, risk reduction counseling, vaccination, and medication prophylaxis. We also have secondary prevention. This involves screening and early detection, diagnosis, and treatment, which can prevent further propagation of disease. Things like routine screening, syndromic testing and management, presumptive treatment, and partner services in EPT. So just remember that DoxyPEP is one piece of the overall STI prevention landscape. I always like to start with a case to put things into context, and this is based on a real person that we saw in our sexual health clinic. This was Igor. He was a 29-year-old male. He took HIV PrEP for HIV prevention. He'd actually been on it for about 3 years, I think. He's sexually active with men with 4 partners since his last visit. He doesn't like to use condoms. He comes to the clinic between his regular appointment with 2 days of green penile discharge. So being a sexual health clinic, we did do our routine testing for HIV, syphilis, and 3-site gonorrhea chlamydia testing. And then we treated him empirically with ceftriaxone and doxycycline. So this is Igor's STI prevention plan, and it actually included both elements of primary and secondary prevention. As I mentioned, he doesn't like the sensation with condoms, so he doesn't use them. And he doesn't necessarily want to bring his partners in or offer them treatment, but he does use the other methods of prevention. So he's been vaccinated with HPV, Hep A and B, men ACYW, and Mpox. And he's medicated, he takes HIV PrEP for HIV prevention. In terms of secondary prevention, he knows to come in every 3 months for his routine screening. He also knows to come in like he did here early if he's having any symptoms for testing and treatment, and knows to come in for presumptive treatment if partners tell him that they were tested positive. So back to Igor, his labs were negative for HIV, but positive for gonorrhea in his urine, pharynx, and rectum. And his RPR was 1 to 128 from 1 to 4 just 2 months ago. So we diagnosed him with gonorrhea and early latent syphilis. We had treated him empirically with ceftriaxone and doxycycline for the penile discharge. And so we called him and extended his doxycycline course to 14 days, in large part due to the ongoing benzazine penicillin shortage. However, he actually returned 6 weeks later, saying, "I got totally better, but now it hurts again when I pee." He has had 7 condomless partners since his prior visit, but he is sure that his regular partners got treated for gonorrhea and syphilis. So he's walking back into clinic with recurrent dysuria and a small amount of discharge. So we again do routine testing and treat him with ceftriaxone and doxycycline. His repeat labs were again negative for HIV. His syphilis titer is coming down, but he did again test positive for gonorrhea, as well as a new diagnosis of rectal chlamydia. I called to give him his results, and he was pretty upset. "This is really frustrating. Is there anything I can do to stop getting STIs?" And this was several months ago, well before the guidelines on DoxyPEP were released, but we did have the data from CROI. And so what he's really talking about is, is there a form of primary prevention, in this case, medication prophylaxis, with DoxyPEP, which now joins HIV PEP and HIV PrEP in our STI medication arsenal. When we talk about DoxyPEP, it's important that we know what we're talking about. Operationally, we're talking about doxycycline 200 milligrams by mouth, ideally within 24 hours, but up to 72 hours after a condomless sexual encounter at any anatomic site. So when thinking about any intervention, the first and most important question is, does the intervention work? In this case, does DoxyPEP prevent STIs? And I don't need to spend a lot of time on this slide because, as Preeti showed us, we have fantastic data from at least 3 recent and 1 older randomized controlled trial, demonstrating pretty clearly that DoxyPEP is safe and well tolerated, prevents STIs in men who have sex with men and transgender women, and at least in the studies right now, did not prevent STIs in cis women in the DoxyPEP study. But we know that it works, but the other side of the equation are, what are the risks of this? So I want to start with concerns about DoxyPEP, and I think this article is actually really interesting. It was released in 2018, around the time of the IPER-gay DoxyPEPs were released, and was written by Jean-Michel Molina, one of the leads of that trial, who actually urged us to take his own trial results with caution, which is pretty rare. However, even if these results are encouraging, they should be taken with great caution. Previous trials of antibiotic prophylaxis have shown only limited and transient benefits. Risk compensation might offset early benefits. Antibiotic prophylaxis might change the presentation of STIs. The impact of doxycycline use on the microbiome remains to be assessed. It might select for antibiotic resistance outside the field of STIs. And the greatest fear by far is the risk of selection of doxy resistance to chlamydia and syphilis. And this is what we're going to go through today. So the first clinical question was, how will DoxyPEP impact sexual behavior? This gets to the idea of risk compensation. I want to start by being very clear that we're not concerned about people having more sex. In some ways, we want people to be comfortable enough to have the amount of sex that they want to have. But one way that DoxyPEP differs from HIV PrEP is that it's not almost 100% effective. DoxyPEP is less so, particularly for gonorrhea. So there is the potential for risk compensation to ultimately lead to more STIs, negating the benefits of DoxyPEP. With that said, that's not what we're seeing. In both DoxyPEP and DoxyVax studies, DoxyPEP did not appreciably change sexual behavior. The second is that antibiotic prophylaxis may change the presentation or diagnosis of STIs. And so far, there's no data that this is true, but it's certainly an area of concern. This is most notably concerning around syphilis, where we're still using serology. As we've seen with HIV testing and early treatment can change serological testing, resulting in delayed antibody formation or even antibody reversal. And so there's concern that, especially with syphilis, where we don't have great diagnostic options, that DoxyPEP could result in partial treatment, delayed diagnosis, or false negative results. And I think those two concerns are relatively minor compared to the major concern about antimicrobial resistance. That includes antimicrobial resistance to STIs like syphilis, chlamydia, MGen, and gonorrhea, as well as concerns about resistance to commensal bacteria. And the reason we're so concerned about antimicrobial resistance is we really have limited antibiotics in the clinical pipeline. And this is particularly notable for STIs, where there are really only 2 antibiotics pending, both of which may have activity against gonorrhea, but we don't have any clinical data on that yet. It's concerning because when we look at what could be our next options for gonorrhea, there was this recent randomized controlled trial looking at ceftriaxone, ertapenem, gentamicin, and fosfomycin for the treatment of gonorrhea. And they found that single-dose ertapenem was non-inferior to single-dose ceftriaxone. However, gentamicin was not non-inferior or was inferior to ceftriaxone, meaning we really do have limited existing antibiotics for treating resistant gonorrhea. In the cases in England that have been highly resistant so far, they've actually had to use ertapenem. And so obviously using a carbapenem for treatment of gonorrhea would be concerning. So we're hopeful that there are future antibiotics on the horizon, but there aren't many options. One that I'll just highlight that may be closer than others is single-dose zoliflodacin, which I can't actually pronounce, but did have a promise in a pivotal phase 3 trial, although we have just a press release and results have not been published yet. So it's hopeful that we'll have some more antibiotic options in the future. But again, we want to be very careful about the selection of resistance. So I'd like to start off a little bit easier, and that's with chlamydia and syphilis, where we believe the risk of resistance is relatively low. For chlamydia, no clinical resistance to tetracyclines has been seen, and we've been using doxycycline for treatment for years. There is some mild concern because tetracycline resistance has been seen in another form of chlamydia, chlamydia suis in pigs, but we have not seen that in people. For syphilis, there's been no clinical resistance to tetracycline seen. And this is important right now because we are using more doxy for syphilis due to the penicillin shortage. The concern about resistance in syphilis actually mainly stems not from doxy, but from the widespread macrolide resistance that was seen from a single point mutation in syphilis. That mutation was so significant and became so widespread so quickly that the CDC now recommends against macrolides or against azithromycin for the treatment of syphilis. Next up, it gets a little more complicated, and that's Mycoplasma genitalium treatment, which is probably the #1 STI I get consulted for these days, rapidly overtaking syphilis. MGen is really challenging because it's intrinsically resistant to several classes of antibiotics, including cell wall and folic acid inhibitors. Concurrently, it has high rates of resistance to protein synthesis inhibitors like macrolides and tetracyclines, and nucleic acid synthesis inhibitors like quinolones. This leads us to, as many of us know, treatment with sequential resistance-guided therapy, with doxycycline followed by either moxifloxacin or azithromycin. That regimen actually comes from this study conducted in Australia that showed the benefits of doxy followed by moxi or azithro, and showed a greater than 90% efficacy for sequential therapy. Interestingly, the theory for why this worked is what's here on the right. It's that doxycycline reduces the bacterial load, and then the second agent helps clear the infection. What's unclear right now is what are the effects of increasing doxycycline resistance? What would happen if it no longer reduces the bacterial load? Will we still be able to clear the infection with the same course of treatment? Next up is the big beast of our concerns, which is gonorrhea. The concerns around gonorrhea are both around tetracycline resistance, not because we use it as an agent, but that if rates of resistance increase, will DoxyPEP actually be less effective for prevention? In addition to the concerns about it being less effective for prevention, there's also the possibility of generating cross-resistance to other antibiotics like beta-lactams, including ceftriaxone. This first study is a modeling study done by Mortimer and Grad, where they looked at tetracycline resistance having two mechanisms of resistance. The first one is a plasmid mediated by the TET-M gene, which confers high-level resistance. We worry a lot about plasmid-mediated resistance because that type of resistance can actually be transmitted from one type of bacteria to another. There are also chromosomally encoded mutations that result in lower-level resistance with MICs 2 to 8. What Mortimer and Grad did is they actually got the sensitivity results from an international cohort on the left-hand side and a US cohort on the right-hand side. And they plotted them by tetracycline sensitivity on the x-axis, sensitive, intermediate, resistant, or high-level resistant, and then by antibiotic by category, so penicillin, Cipro, ceftriaxone, and azithromycin. And what they found was that co-resistance is more prevalent among isolates with chromosomally encoded tetracycline resistance than plasmid-mediated resistance. And what that means is that if DoxyPEP selects for tetracycline-resistant lineages, there is the potential for increased resistance to other antimicrobials as well. However, DoxyPEP primarily selects for lineages with plasmid-mediated resistance. We actually may observe a temporary decline in resistance to other antimicrobials due to less co-resistance in these lineages. That's a lot of really complicated ID stuff, but the key point and most important point is that surveillance is really necessary to know what we are selecting for as DoxyPEP gets rolled out on a large scale. And that's where things like SURGE and the gonorrhea resistance projects are really critical to monitor as DoxyPEP rolls out. It's also important that this is done at the national level, because not all people and all sites are actually affected equally. This is tetracycline resistance by HHS region and sexual preference. And you can see that it's important that surveillance includes multiple regions and multiple populations, as it's all different. Those are our STI resistance concerns, but we also have concerns about commensal organisms. This was a systematic review looking at the impact of tetracyclines on antimicrobial resistance of normal flora. They actually only found 7 articles fulfilling their inclusion criteria, most with a high risk of bias, highlighting how limited our data is in this area. What they found is that limited data from small prospective studies suggest that oral tetracyclines for 2 to 18 weeks do increase resistance in subgingival gastrointestinal, and upper respiratory flora. But given the limited data, it's important that we really monitor this as ongoing. And STI and commensal bacteria was actually measured in some of the studies mentioned earlier. So starting with the DoxyPEP study, we have gonorrhea on the right-hand side and Staph aureus on the left-hand side. Staph aureus was cultured from the oronasopharynx in 45% of participants with a baseline doxycycline resistant rate of 12%. 1 year later, Staph aureus colonization was significantly less, down to 16% in the doxycycline group and 8% in the standard of care groups. Sorry, doxycycline colonization was significantly less, but the prevalence of doxycycline-resistant isolates had increased in the doxycycline group to 16%. And so what you see is a reduction in colonization with an increased rate of resistance. In gonorrhea on the right-hand side, cultures were available for about 17% of gonorrhea infections, with baseline tetracycline resistance of 27%. After enrollment, resistance was 38% in the doxycycline group and 12% in the standard of care group. And DoxyPEP did appear less protective for tetracycline-resistant gonorrhea, although the sample size was small. So what you're seeing in both of these examples is a reduction in colonization or infection with increased rates of resistance. And these are trade-offs that we likely need more data to better understand in the long term. Next, we have the DoxyVac study. Again, starting on the left-hand side with gonorrhea. Gonorrhea cultures were available for 15% of gonorrhea isolates. And baseline tetracycline resistance was 100% with no high-level resistance. In this study, the prevalence of high-level resistance was actually greater in the DoxyPEP group than in the standard of care group. On the right-hand side, they looked at MRSA and throat swabs and ESBL and anal swabs. And they actually did not see any difference in detection between the DoxyPEP and the control groups. So the overall conclusion from both of these sets of slides is that the efficacy of DoxyPEP for gonorrhea is likely going to differ depending on the prevalence of tetracycline resistance. For Staph aureus in particular, DoxyPEP is associated with decreased colonization rates, but increased resistance. And again, we need more data to better understand what these mean in the long term. The concern is that DoxyPEP will result in increased doxycycline usage. To fully balance DoxyPEP consumption with reduction in antibiotics for treatment would require an incidence of 7 to 8 infections per person per year. But as Preeti highlighted from the guidance, we're generally infecting people who have one or more infection, or treating people who have one or more infection per year. And so we will increase doxycycline usage, and we need to closely monitor what the side effects of that are. Next, we'll talk a little bit about implementation and who should be given DoxyPEP. One of the things that really came up a lot when we were discussing implementation at the beginning is should this be like PrEP, where we're offering or informing everyone about it when they walk through our doors? Well, as we just discussed, there are unknowns, and we really do need to figure out the optimal population that reduces STIs while minimizing antibiotic usage. Michael Traeger from Fenway, in a study that Preeti highlighted earlier, really put together this great modeling exercise to look at the potential impact of DoxyPEP. In this study, he looked at individuals at Fenway from 2015 to 2020 and looked at 10 different DoxyPEP prescribing strategies to evaluate the proportion of individuals prescribed DoxyPEP, the proportion of diagnosis averted, and the number needed to treat. When comparing different strategies for prescribing DoxyPEP, the most efficient strategies were based on STI history rather than HIV status or PrEP use, suggesting that the clinical trial definitions and some of the guidance we've seen earlier, like STIs in the past 12 months, are really good starting points. And again, we have all the different guidance that we talked about earlier. So when thinking about who to offer DoxyPEP to, I really think about it both in two ways. One is the population, and one is an individual's vulnerability. In terms of population, we know that there's a benefit in cisgender men and transgender women. There may be some benefit in cisgender men who have sex with women, especially men who have sex with men and women, as well. And there's no evidence right now that supports using it in cisgender women because of the study highlighted earlier. In terms of vulnerability, people who have had an STI, at least one in the past 12 months, are clearly good candidates for this intervention. For persons taking PrEP or have 0 STIs but are engaged in non-monogamous condomless sex, it may make sense to assess for DoxyPEP if they have increases in risk or vulnerability coming up. For example, they're going on vacation, they're going on a cruise, or other things like that. I don't think it makes sense to offer to everybody presenting for care given the data we have so far, but certainly if the risk assessment puts them in a different category, they may be. The next question is, what is the proper interval for STI testing for individuals on DoxyPEP? This is a really complicated question because patients who are taking DoxyPEP often ask if they can come less frequently. But as we saw earlier, while DoxyPEP is incredibly effective, the efficacy is between 60 and 70%, so it's not 100%. And so in general, we shouldn't change our screening practices for DoxyPEP and continue to screen individuals vulnerable to STIs every 3 to 6 months. Once you've decided you want to provide DoxyPEP, what do you do next? How do you do that? In terms of explaining the risks, I think it includes both the known risks or side effects, as well as the unknown risks. In terms of side effects, skin photosensitivity, especially in the summertime, can occur. Wearing sunscreen, limiting sun exposure, and avoiding tanning beds can really help prevent skin injury. Esophageal injury and irritation can occur, and they do recommend that Doxy be taken with an 8-ounce glass of water, and individuals remain upright for up to 30 minutes after dosing. GI adverse effects are common. Taking Doxy with food may help alleviate nausea or GI upsets, but these can be severe enough to require cessation of doxycycline in some cases. There are also the unknown risks that we need to talk about, things like antimicrobial resistance and microbiome changes, which could include weight gain. So how do you practically prescribe DoxyPEP? So since I don't have screenshots of everyone's different EMR, I'm using this old school prescription pad. And I want to start with the drug name. You can actually use either doxycycline hyclate or doxycycline monohydrate. You can use immediate release or delayed release. The immediate release formulations are more widely available and usually cost less than the delayed release formulation. Hyclate is usually cheaper than monohydrate and has less GI discomfort. Sorry, hyclate is usually cheaper while monohydrate usually has less GI discomfort. One other thing I'll highlight is most of the time when we get a rejection for a DoxyPEP prescription, it's because we ordered the wrong drug for the patient's insurance. And so each insurance can be a little bit different. So speaking with the pharmacist may help overcome that barrier. The next is to provide detailed instructions. When we first started prescribing, we didn't always do this, but it's amazing how often patients refer back to the bottle for how to take medications, and this is very important. This also comes up if you're going to start someone on DoxyPEP who also has chlamydia. We have stopped co-providing at the same visit chlamydia treatment and DoxyPEP because patients were confusing it. What we try to do now is to give them treatment for chlamydia, and then when they're finished with the chlamydia treatment, send the prescription in for DoxyPEP. That way we avoid confusion on how to take the medication since they are different. I also think prescribing educational materials are important. While we're working on internal materials, we've utilized these San Francisco materials a lot, including this information sheet and guide on how to take that we can walk through with patients. Finally, and maybe the most complicated and controversial topic, is how many pills to give. I think that if you're seeing patients quarterly, the best approach is to aim for a 3-month supply based on their individual expected sexual activity. For many patients, 60 tabs or 30 events is a reasonable number, but we've gone higher or lower depending on a patient's usual amount of sexual encounters. This does need to be an individualized process that can often be challenging to operationalize. This is my Epic example for sites that use Epic, and I know that Gary said the slides will be made available. In terms of following patients, patients do not necessarily need labs prior to initiation, but I do not start on patients who are symptomatic. It makes more sense to wait, make a diagnosis, and treat them before starting DoxyPEP. Quarterly STI testing and annual CBC, LFTs, and creatinine are the current recommendations. In terms of treatment, it doesn't differ much, but the big difference is to think about an in-person exam and deferring empiric treatment for exposure, since that's exactly what we're using DoxyPEP for. So going back to our patient, Igor was prescribed DoxyPEP. He returned to clinic 4 weeks later. It hurts when I pee and I have a lot of green discharge was his complaint. His labs were repeated plus gonorrhea culture. And we treated him with gentamicin and azithromycin, second-line therapy, because we treated him twice in the last 10 weeks. His labs again returned positive for urine and pharyngeal gonorrhea. and susceptibility testing showed a high level tetracycline resistance. Some things we still don't know is whether tetracycline resistant gonorrhea will work, or sorry, if prophylaxis will work for tetracycline resistant gonorrhea. But one of the things we often get asked about, and I know was one of the Q&As already, was what about vaccination for preventing gonorrhea? And there has been some interest in using 4C Men-B, the Men-B vaccine, to prevent gonorrhea. There are 3 observational studies, including one involving New York City that Preeti was a part of here, that looked at different populations, MSM living with HIV, adolescents, and teens and young adults, that showed a 2-dose series of Men-B vaccine was between 40 and 46% effective in reducing the rates of gonorrhea in these observational studies. But to confirm observational data, we really needed a clinical trial. And that brings us back to the DoxyVac trial. The DoxyVac trial was really interesting. As Preeti had mentioned before, in their original 2018 DoxyPEP study, they didn't see a decline in gonorrhea. And so when they designed their fully powered study, they actually included 4 arms: a DoxyPEP arm, a control arm, a vaccine arm with Men-B, and a DoxyPEP plus Men-B vaccine arm to evaluate the effectiveness of the Men-B vaccine for gonorrhea reduction. And they actually presented their data at CROI 2023 that demonstrated a 51% reduction in gonorrhea incidence. At that time, the DSMB recommended stopping the study and that all participants be offered Doxy and the Men-B vaccine. However, there's definitely more to the story, since there was a discrepancy between the interim and final analysis that's ongoing, and I've not seen any updates to this. Hopefully, we'll learn more soon when they publish the paper. But as of right now, we really don't have any additional data on whether Men-B vaccine worked in a randomized controlled trial. Just to give a summary of what we talked about, we really talked about more than just DoxyPEP. We talked about STI prevention. We're in an era of STI prevention choice, and patients should be aware of their options. DoxyPEP works to prevent STIs in men who have sex with men and transgender women living with and without HIV. DoxyPEP does not work to prevent STIs in persons born female. There remain unknowns about the overall impact, risks, and unintended consequences of DoxyPEP that potential users should be aware of. 4C Men-B may reduce an individual's risk of gonorrhea. 4C Men-B vaccination prevents against gonorrhea in observational studies, but randomized clinical trial data is not yet confirmatory. What we really need are real-world studies to help us understand the risks and benefits of STI prevention modalities like DoxyPEP. And most importantly, flexibility is going to be key and will change as we learn more. As a reminder, I'm from the National Network of STD Prevention Training Centers, and we do have all these trainings available for people who want to learn more, including the National STD Curriculum, the mobile app, and the Clinical Consult Network if there are questions. We also now have some e-health learning courses where you can get MOC as well. And with that, I will stop, and I think Preeti and I will take any questions you might have. Thank you very much.
Thank you, Dr. Zucker and Dr. Pathello. We really appreciate your presentations today. If anyone has questions, please type them in the Q&A box. We'd love to answer questions. And as Dr. Zucker said, a copy of today's slides will be sent out via email, as well as instructions on how to access your continuing medical or nursing education credits. Today's webinar was recorded, and we will be posting it up on the New York City Prevention Training site sometime next week. So right now, I don't actually have any questions. There were a few questions that came up during the webinar that weren't answered, actually. And they were mainly about things that were going to be reviewed by Dr. Zucker, which we did do during his presentation. But we can give it a few minutes and just see if any questions come up. And related to that, we did have a poll at the beginning of today's presentation, just trying to get a better idea of the landscape in New York City on DoxyPEP. And so we have a quick survey that we'd love to share. I'll put that in the chat box. Really just want to get a better sense of everyone who attended today. I know some people joined us late. If you're providing DoxyPEP, if you're referring out, and then what your facility name is. So I put a link to that survey in the chat. We'll also send it out via email to everyone who attended, just to get a better idea. So I don't actually see any questions so far. I don't know if either of you had any last comments or anything you'd like to add.
Nothing extra for me. I think we covered certainly a lot during today.
Yeah, and I mean, it's obviously, you know, a newish intervention. There's a lot of work being done around DoxyPEP in various areas that we touched about. So looking forward to returning at some point, and kind of giving updates and seeing where we are, you know, months and even years from now.
Great. Well, thank you both. Really appreciate your presentation. If anybody does have questions later on, please feel free to reach out to us. We're happy to see everyone today. Have a great rest of your day, and thanks again.
Hi, Zoe.